We're going to start this evening with Giancarlo giving a brief overview of medical aid in dying and Act 39, and then we're going to be moving on to a presentation with Dr. Diana Barnard on the basics of palliative care. So again, on behalf of Patient Choices Vermont, thank you so much. We're thrilled you could join us. I hope that you learn a lot and then keep visiting our website to keep learning. I'm going to pass it over to Jen. Jen is our program manager, and she leads all of our outreach and education efforts.
Thank you, Amy, and thank you so much for joining us tonight. We're delighted to have so many of you with us. We are recording the session tonight, so you should feel free if you have any privacy concerns at all. You should feel free to be off camera and use any old name you'd like when you're signing in. And please feel free to introduce yourself if you'd care to in the chat with just your first name and where you're joining us from. And as Amy said, I will be doing a brief presentation followed by Dr. Barnard's presentation. And we will welcome questions at any time. We may need to keep the program moving, but as I said to one of our participants already, I am happy to stay on afterwards. And excuse me, sorry. Trying to do two things at once. I am happy to stay on afterwards and answer questions as long as people would like. Act 39 and medical aid in dying in Vermont. Patient Choices Vermont is a nonprofit organization. We're funded by donations and grants. There are no federal or state funds available for this work. The organization was founded in 2002, successfully advocated for over 10 years for the passage of Act 39 in 2013. And the act was then amended in 2023 to allow non-residents to access MAID in Vermont. And as Amy said, we provide education and outreach around Act 39 and medical aid in dying in Vermont. And we're really run almost entirely by volunteers. Medical aid in dying has a very specific definition, and I don't often read slides, but I do read this one because there are a lot of elements that go into this definition, and we want to make sure that everyone understands them. Medical aid in dying allows qualified adults who are terminally ill and who are capable of making their own decisions the option to receive a prescription medication to be self-administered to bring about a peaceful death at the time of the patient's choosing. And it's important to note that medical aid in dying in Vermont can only be accessed by qualified adults through a very specific process that's laid out under Act 39. The qualifications to access MAID in Vermont is you have to be an adult, you must be 18 years of age or older. You must have a terminal diagnosis and a prognosis of 6 months or less. You must have the mental capacity to make this decision, and that you must have that mental capacity through the entire process, including at the time of ingestion. You need to make an informed and voluntary request. Participation in MAID is always voluntary for everyone involved. And you must be able to self-administer the medication. And again, it's important to note that all of the qualifications must be met in all cases. There are no shortcuts, there are no exceptions. The process to access medical aid in dying is also laid out in Act 39, and this is available on the PCV website as well. You need to make 2 oral requests to a prescribing physician, and those oral requests have to be at least 15 days apart. There's a built-in waiting period there. You also need to make a written request to the prescribing physician, and it's a form, it's a Department of Health form, and it's available on our website in the Clinician's Guide and also on the Department of Health website. The form needs to be witnessed by 2 unrelated adults who are not part of your care team. And once you've completed all of that, you need to have a second physician confirm that you meet all of the qualifications and you followed the process. After that process is completed, your prescribing physician can write the prescription, and you'll work with your prescribing physician to determine when that prescription will actually be filled. On the day of ingestion, we found that this is something that people are very curious about, but a little shy about asking, so we just put it right in our presentation. A patient will take two medications for nausea about half an hour before they'll take the medical aid in dying medication. And then after confirming again that they want to do that, they want to ingest the medication, the patient needs to drink the made medication without assistance. It's a compounded medication of 5 different elements, and it comes as a powder, and you mix it with a clear liquid, about 2 ounces of water or clear apple juice. The patient falls asleep generally very quickly, within 5 to 10 minutes, and will not awaken. The time to death can be variable. Again, that's something that you'll want to work with your prescribing physician to identify any elements that might be present in your particular health journey or your prior treatment that may affect the time to death. Most are within 5 hours. It can be longer. And we strongly recommend hospice enrollment to anyone who's accessing MAID in Vermont. Death can be pronounced by a hospice nurse if the patient is enrolled, but there are an awful lot of reasons to enroll in hospice, an awful lot of support and symptom management that's available to hospice patients. So again, we do recommend that. Medical aid in dying is always voluntary. Qualified patients can choose to pursue MAID. It's always the patient's choice, and you can stop the process or rescind a request at any time. You can start the process and then perhaps decide that that's not the option you prefer to continue to pursue, and you can make that decision right up till the moment of ingestion. Healthcare providers are also not required to participate in medical aid in dying. And so sometimes patients will need to look further than their original doctor to find someone who's willing to prescribe for them. Again, voluntary for everyone involved in the process. A doctor who's prescribing the medical aid in dying medication will inform you of all of your end-of-life choices: MAID, hospice, palliative care, palliative sedation, voluntary stopping of eating and drinking, so that your decision to pursue MAID can be made in a voluntary and informed way. And we have resources available. They're on our website. And if you come to any of our in-person presentations, or you just let us know that you want the actual physical cards, we have what we call a pocket card with some resources and some questions to address with your doctor if you need some help getting that process started. And again, it's so important that we put it in 2 slides back to back. We strongly recommend hospice enrollment. Medical aid in dying is not suicide. There's a legal difference under Vermont law. Someone who uses medical aid in dying is not considered to have died of suicide. Your cause of death on your death certificate will be your underlying illness, and you will be deemed to have died of natural causes. That's a question that comes up a lot. It's not euthanasia. Again, self-administration is an absolute requirement of this process. No one can give you the medication. You must be able to ingest it yourself. And it's not for everyone. We are not here to advocate that any individual use medical aid in dying. What we are here to do is provide information about something that is legal in Vermont and available to qualified folks who go through the process. I strongly encourage you to go to the Patient Choices Vermont website and maybe set aside some time, go back a couple of times. It's very information dense. There's a lot of really good information there. So you'll want to give it a thorough review. All of the information that I've just shared about the qualifications and process for MAID are on there. There are links to the Department of Health forms. There's some personal stories as well. There are some patients and their families who have been very generous with us in sharing their journeys with medical aid in dying. And so those are there for a more personal perspective. We have a clinician's guide that has a number of sections with wonderful information, both for you and for medical providers. There's news, there's educational events, and I strongly also encourage you to sign up for our mailing list if you haven't already. We have 2 groups of volunteers. One, the Wayfinders are not official PCV volunteers. They're affiliated with us. They're an independent and collaborative group. And they work primarily with non-residents, supporting them with lodging, logistics, arranging caregivers, all of the challenges involved in coming to Vermont from another state to access medical aid in dying. And there are links to some of our wayfinders on the PCV website. And then we have a helpline. It sounds like a phone line. Very few messages coming through phone. It's really more of a web form. And we have 4 wonderful volunteers who work a week at a time to respond to all of the messages that come in over the helpline. And generally, that's folks who are looking for information about the process of accessing MAID. They have some specific questions, perhaps, about their general situation. And the people who are on the helpline show a lot of dedication in making sure everyone gets a prompt response with links and information and everything that we're able to give them to support them in their choices. I am delighted to introduce tonight's speaker. Dr. Diana Barnard is someone who's been involved with Patient Choices Vermont from the very beginning. She is an absolutely outstanding advocate and educator. I often say to other folks associated with PCV that I cannot listen to Diana for more than about 2 minutes without learning lots of things. So you will gain lots of information tonight. Dr. Barnard is board certified in family medicine as well as hospice and palliative medicine. She's a founding board member of PCV, and she's in great demand across the country for other educational, legislative, and advocacy efforts related to medical aid in dying. She was an associate professor of family medicine at the UVM Medical Center for more than a decade. And she's truly a passionate advocate for high quality, genuine, patient-centered care. And we are delighted that she's agreed to join us tonight to talk about Palliative Care 101. So, Dr. Barnard, please.
Thank you very much. And thank you, everybody, for your time and attention. I am going to pause in a second for my tech support to get my slides loaded, but we are going to do the second part of our presentation this evening is what I'm going to call Palliative Care 101. And then after I'm done, we'll be able to take questions you have around palliative care, around how it relates to medical aid in dying, or anything else that strikes your fancy. Okay, so again, a very broad overview of what palliative care is. I just am I don't get surprised very often, but it's a regular thing for people to have a lot of misperceptions and misunderstanding about what it is and what it isn't. So we're gonna sort of go through the fundamentals, and then I'm very curious about what questions or comments you might have. So here's what it is, and sort of broken it into different sections. It is specialized medical care for people with serious illness. So if you're diagnosed with a serious illness, whether it's something that you might live with for a long time or not, if it's something that's going to create symptoms and create challenges for you to deal with, that is a perfect time to think about a specialist who can help you take a broad overview of what your treatment, what the quality of your life, and what your values may be throughout your disease. So some of those serious illnesses could be things like cancer, could be neurological degenerative diseases like ALS. It could be something like advanced heart failure or COPD or other breathing issues. Really, any serious illness that creates symptoms is enough for you to potentially benefit from palliative care. Another unique thing about palliative care is that it really is meant as a discipline to address the needs of the patient and the family. Many specialists in medicine treat individual patients, and of course they have loved ones that come with them, but they're not often included in the services that you provide. But with palliative care, it really is part of the core discipline to spend time with family members and loved ones of someone living with a serious illness to support them and to address their needs as well. The main goal of palliative care is to provide relief for the signs and symptoms and stress that come along with a serious illness. So it could be something very practical, like helping with pain or helping with shortness of breath. It also could be something that's much different, like how do you manage the fact that you're 40 years old and you have children at home, but you have to go for your chemotherapy treatments every week? Or how are you managing the existential angst of why you have been challenged with an illness that you did nothing to bring on yourself. So it's a very broad scope of symptoms and stress. And we sometimes use the word suffering. And one of the things that I'm always reminding people about is that, palliative care aims to prevent, identify, and treat suffering. And suffering comes in many different flavors, depending on the day and depending on the person. The goal of palliative care is to focus on the quality of life, the overall quality of life that a person navigating serious illness is dealing with. And again, for patients and families. And the bottom one is almost the most important of what I just said, which is it's appropriate to consider the role of palliative care at any age, at any stage of illness, and right along with those of you who are diagnosed with an illness that you are really hoping you're going to be cured from and it might go away. Palliative care is also known to be an interdisciplinary team sport, as I like to say. So many different people coming together are needed to address the different kinds of symptoms and stress and the suffering that you may experience. So there may be doctors or nurse practitioners, social workers should be number one on the list because they're just great at everything. Chaplains and case managers, but also palliative care can also involve other specialties like practical therapies, like physical therapy and occupational therapy, or psychotherapists. If you're dealing with a child who's living with an illness, you might pull in child life. So it really could be provided by a variety of different disciplines, all of whom are working together to focus on the quality of your life and to address and prevent and to treat any suffering that you have. It is important to identify what palliative care is not, and this is where the misperceptions come in. So, many of you probably recognize this Grim Reaper, and it's stark and it gets people's attention. And unfortunately, and I have my colleague, Dr. Patty Whitney, for sharing this term with me first, palliphobia. It's not a real word, but the belief that palliative care, that people have fear of palliative care because they worry that it means I'm dying right away. It means I have to go on hospice. We hear, terrible things like it means giving up. It means I'm definitely at the end. It means I have to be ready to die. The worst thing I could hear is for someone to say there's nothing more we can do, because that is just, you should not be practicing medicine. There is always more that we can do. It's a matter of what kind of care somebody needs and matching that to the stage of illness they're at. And it certainly is not doing nothing. And always a good opportunity to remind people it's not about just giving you medications like morphine and keeping you comfortable. Morphine is a very powerful drug, and it can offer great comfort and treat many signs and symptoms associated with serious illness. But it's so much more than that, so much more. This is a busy slide that I don't use very often, but it's a visual and just a different way to talk about what's the ideal medical care that one might want. And so if you think about this graph way over on the left at 0, when you're first diagnosed with an illness, the first thing you're going to, of course, ask yourself, what is it? What can be done? Can I make it go away? And you're going to want all of the energy to focus on making things better or going away. However, you're going to have fears. You're going to have a few symptoms. And at some point, the treatments for your illness are not going to be as effective. So ideally, palliative care would kind of blend in right alongside as your curative options are diminishing. Your palliative options are increasing. And that line ideally wouldn't even be a straight dotted line, right? It would go up and down, because if things are going well, you're really focusing on your curative treatments. If you're having an acute hospitalization and things are not going well, you need more palliative care. So that goes along as long as you can. And then at some point, one might recognize, oh, I am definitely in the final chapter of my life. The curative treatments are no longer offering anything that can help me. And in fact, they sometimes can start to be harmful. And you would shift to a laser focus on making the most of the final chapter of your life. And for practical and billing purposes, we use these numbers like having less than 6 months to live. That is an educated estimate, and it is only an estimate, and people surprise us all the time. I think a lot of people on this call might already know, but people surprise us many times because we overestimate how long they have to live. And we don't give them the opportunity for this beautiful thing called hospice to play a role in their lives at the right time. So it's great and it's wonderful, and people should be sometimes on hospice for much longer than 6 months, 9 months, a year, more than a year. Unfortunately, many of us hear that people are on hospice for too short a time. 3 days, 10 days, 2 weeks, not enough. So again, in the ideal magical world, you would have your hospice care for as much time as it makes sense for you, and then you would have an attentive team paying attention to after death care and the bereavement needs for those that are survivors of those that have died. And that is a really important part of the hospice benefit. So, hospice not only takes care of you while you're living and dying with your illness, but after you die, they continue to take care of your family to be sure that they're moving forward with grief and have the right support. And if there are signs that things are not going well, to get you more professional help. And I can imagine that perhaps many people on this call think about their own death, and it's probably affected by deaths that you might have witnessed or been a part of. So, how people die and how you deal with the grief after someone dies has a profound effect not only on how you live, but certainly when your own time comes, as they say. So, really important part of this life and death continuum. Um, Somebody just gave me this cartoon today, so I stuck it in here. Um, this is our reminder slide that as much as I talked about palliphobia and that people fear palliative care because they fear it means death, the truth is that life is terminal and we are all going to die. And it is important in some part of your psyche and on some part of your medical team for somebody to be holding that reality and paying attention to what you need to know about that reality and perhaps a little bit about how close it's coming. And that's exactly one of the things that palliative care providers can do. Um, these are just a couple of quick pictures, again, to just give you a very brief visual about, before the mid 1900s, people died very quickly, either by accidents or illnesses or even just infectious diseases that we really didn't have any good treatments for. So people would be sick and then they'd be dying. And so in this picture, you even have a what appears to be a young, she doesn't look that sick person, and she's dying. Unfortunately, since the 1900s, all too often dying can look like this in an ICU with a whole bunch of tubes and machines and not a lot of opportunity to do some of the things that you might have done here, which is be together with your family, say important words, honor that dying can be is a natural part of the life cycle. Now, going through this is great if it's going to get you back to walking around and living well, but it's not good when it happens at the end. The challenge is that with modern medicine, people are actually living much longer with a lot of disease burden. So instead of dying quickly when you have an illness, people are living longer. That's wonderful. We're celebrating that. We're so happy about that. The problem is the more advanced your illness gets, sometimes it gets confusing. Am I living or am I dying? And people will sometimes handle information and make different choices about what they want or what's most important, depending on which side of the line they are on. And the honest truth is that more often than any of us are comfortable with, we're not sure. We don't always know for sure. So what do most people I talk to hope for? Well, they want to live as long as possible. They want to live the end of their life as well as possible. And depending on your perspective and my and the day I think about it, you want to avoid a bad death. And sometimes you want to actually aim for a decent death. So this is kind of the general rule, but it's hard to get it all exactly right. I think it's really important for people to hold this reality. There are some things worse than death. I should say for most people, because everybody's different. And some of what I say today may sound cockamamie and may not make any sense to you, and that's perfectly okay. And for other people, it's going to feel just right. And for most of us, it's somewhere in the middle. But if death is a reality and it is coming to all of us, and we're able to hold that, you might think about, well, what would be bad if death comes before I'm ready? You could have uncontrolled symptoms because people are worried about trying to cure your illness rather than focusing on your comfort. You might suffer in some of those many ways we talked about before, whether it's physical or psychological or existential or spiritual. If you die before you're ready, you don't have time for this beautiful thing called life closure. The ability to recognize what's coming and circle it in and tie it up. You might die where you don't want to. You might leave your loved ones and those bereaved completely unprepared for what's coming, and they won't have the support to move forward in the healthiest, most functional way. On the other hand, when you recognize that death is coming, there's an opportunity to talk about it, to be prepared, to have discussions around treatments that may no longer be helping you. Not some people want to go for that Hail Mary and want treatment right until the end because living every second is what they want. But for many other people, that's not true. And when the treatments start to harm instead of help, it might be time to shift to a different treatment. You have time to close up your life, to get your affairs in order, to make sure your loved ones aren't left not being able to pay the rent or understand exactly what you want to happen with your body or how to celebrate your life. There is an opportunity to heal things because life is full of challenges and things don't always go well. And when time is short, it is sometimes an opportunity to heal some of those relationships and conflicts. I have seen amazing things happen. Is it all beautiful? Are we all sitting around all day singing Kumbaya? No. But does it have deep meaning? And it can be a beautiful part of life? Yes. And of course, those important things that we so often hear in books that we read about dying well and living well till the end, basic things that are really important and powerful to say to people, like, thank you for being a part of my life. I love you. I forgive you for the things that you have done that might not have been great. And please forgive me for the things that I have done. These are very powerful tools that can lead to a more peaceful death for many people. So, what is the range of what palliative care providers can do? And remembering that, unfortunately, palliative care is still a relatively new specialty. It is an under-resourced specialty. We do not put as many of our Medicare dollars, of our healthcare dollars into resources specifically for palliative care. So there's a broad range of things that can be done, but it is also true that palliative care and palliative care services are not as broadly available as we would all like. The most important thing that palliative care providers do is to listen. They listen deeply to understand who are you, what's important to you as you navigate your serious illness and as your life comes to an end. So listening and understanding who you are is probably job one and the most important thing. What palliative care providers do is that they sit with the reality and understanding that life is terminal and that death is coming at some point. They have comfort in sitting in that space and exploring it. And they also have specialized skills to understand, are you ready for this? How can I help you be ready? Are you not ready, but you need this because time is short and we must push in talking about something that is very uncomfortable. These kind of skills come with specialized training, and they can be really important when you're at that tender time. There are a whole host of things that palliative care providers can do. Many of these things can also be done by other members of your healthcare team, but this falls within the specialty of our focus. Advanced care planning. So, talking about those important documents that you need to have that help you manage your healthcare wishes and what treatments are right for you and who we should be talking to you as we make decisions about what's best. Navigating complicated treatment options. Sometimes in more advanced illnesses, it becomes really confusing about what's best. And what's best depends on who you are and what your values are. So putting all that together is really important. Managing symptoms, thinking about suffering, making sure that all of your providers are coordinated and understanding your values. That complicated word of prognostic awareness means being prepared when time is short and understanding the clues that will tell you that time is short. Supporting your family. Again, sometimes maybe you're thinking that your cancer treatment is really starting to be burdensome and you're not thinking you want to do more treatment, but your daughter is really pushing you. Come on, Dad, I'm not ready to lose you. That daughter deserves support and understanding as well. And palliative care providers can bring people together in understanding when there are those natural tensions in the family about what's right or what's best to do. And they can help you have a plan for the end, whether that plan is going to have to be implemented tomorrow or in 2 weeks or in 2 years. Translating the hopes that you have for the end of your life into a plan is vital in order to help it happen. You can't just sit back and wish for that good death. You actually have to actively engage in being prepared for it. I wanted to just put this slide up here just to remind you that I could have titled this slide Treatments That Could Save Your Life and Also May Cause Suffering. Because remember what I said before about when you have more advanced illness and you're trying to figure out each of these things, does it help or does it hurt? Being on a ventilator, a breathing machine, great if it's short term and you're going to come out on the other end with a quality of life that's acceptable. Not what most people want at the very end of their life. Resuscitation, being on dialysis. People can live for years on dialysis and it's a wonderful tool. And for many people, there reaches a point when it's more burdensome. Or starting dialysis when you're 55 and have chronic kidney disease is one thing, but starting it when you're 85 and you're living with metastatic prostate cancer is a totally different thing. We need educated people to help us sort out whether this thing is helping or hurting. Artificial nutrition, surgeries, tubes, stents, chemotherapy, immunotherapy, all of these treatments, these wonderful treatments that we have in medicine that can prolong your life and be absolutely the right thing for you, can also reach a point in which they're not. And that's really a decision that you want to have with expertise on many levels to help you make the best choice for you. I put this back up here. This is actually the symbol that I've had on every slide along the way, and it's a Swahili symbol, and it is for strength and humility. And I like to remind people that managing serious illness requires incredible inner strength and resolve, and it definitely brings about a lot of humility. And so I like to use this symbol as a reminder of the work. That's the end of my slides. Now we can chat.
Thank you so much, Diana. That was wonderful as always. Who has questions? And if you do, you can either use the raise your hand function if you'd like, or you're welcome to put your question in the chat. Would doulas be considered palliative care providers?
That's a great question. Yes, I would say, you mean doulas? Doulas is the general term. There are some doulas that focus on the beginning of life. There are some doulas that focus on the end of life and some that do both. So anybody that is listening to you and attending to your suffering is a part of the palliative care team. And I know if I was a palliative care provider and we had the opportunity for a doula to help support patient and a family, that would be a wonderful resource.
I have a question. I'm not Um, why would somebody even start a course of chemotherapy? I'm just using that as to just before meeting with a palliative care team. Why wouldn't, as soon as you get a diagnosis, your next office visit would be a palliative care team rather than another specialist along the way?
That is a wonderful question. One of the reasons I love giving presentations like this is the questions that come because they're always so poignant. Um, That is a remarkable point. And what I think you're sort of saying is if you were diagnosed with a serious illness, before you engage in active treatment, wouldn't that be the perfect time to have somebody with particular skills in doing all of the things that we just talked about, listening to who you are, making sure you understand your illness, making sure you understand the treatment that you're being proposed to be given, making sure that your intense emotions around being given a life-limiting illness have settled to the point that your brain can process the information. This is probably one of the biggest frustrations I have. When people are diagnosed with a serious illness, of course, one of the many emotions you might be feeling is fear. And many people want to rush into treatment. And unfortunately, our modern medical system, well, there's two ways that things happen. Things happen too fast or too slow. That I see a lot of people who are given a serious illness diagnosis, and then when they are in a moment of fear and confusion and still processing the information of the diagnosis, are then given a very long list of the treatments that are going to come and given an appointment and rushed into treatment before they've even had time to process what's going on. So I would say in a perfect world, there would be a pause and a deliberative moment to be sure that you have heard the information and processed it before you dive into treatment. I think because people are afraid, because a lot of doctors want to do and want to help. And the only way they know how to help is to do. And so they offer you what they have. And so for an oncologist, that is cancer-directed treatment, chemo, immunotherapy, whatever it is. So I think it's unfortunate that many people don't have the opportunity for that palliative care pause. But I can tell you, if I was diagnosed with a serious illness, I even say if I show up in the emergency room, I'm going to say, I want palliative care. Because what do I want? I want somebody who understands who I am, what my values are, so that whatever problem is going on, we do the treatment that's right for me. So I hope that anybody on this call that's diagnosed with a serious illness would have that opportunity. And I should also mention that even the doctor who's treating you might have palophobia. So keep that in mind.
Thank you. Eileen has a question in the chat, and Eileen, you and I need to talk about something else entirely. Is palliative care covered by insurance?
Again, another great question. So the short answer is yes. And then there's a caveat. So if you are diagnosed with a serious illness and you see a palliative care provider that is covered by standard insurances, by Medicare, you can see a physician, you can see a nurse, you can see a social worker. Those are all covered services. Many people living with very advanced illness are using home health services. And many people have there's two kinds of home health. People that come to you, right? Come to where you're living to offer you health care. There's regular home health and there's hospice. Unfortunately, in some ways, the hospice regulations are very strict about the things that are able to be covered and the things that are not covered. And with home health, you're able to have it temporarily and then kind of go back out. Palliative home health has to be billed under your regular home health benefit. And it means you have to be home fast, meaning you're kind of stuck at home or it's really hard for you to get out of home. And so many people living with a serious illness are on regular home health, would like to access palliative home health, but doesn't actually exist because there's not a robust payment structure. I'm sorry to say that it comes down to payment, but it does. And so for people that are getting home health services, it's a little bit more confusing about what palliative care is and what exactly is covered. And perhaps our hospice nurse, Jason, has a little bit more to add to that. I feel like that was confusing. Did I answer the question? Um, for the most part, when you're an outpatient, it is. When you have very advanced illness, and if you're stuck at home, you gotta work around it because of insurance.
Thank you. And actually, Jason had his hand up next.
Good evening, and thanks so much for calling on me and making this space. This is always so informative. I really appreciate, Dr. Barnard, your presentation. I'm an oncology nurse here in Vermont, and so as you can imagine, I work with so many patients and families who are going through an initial diagnosis or maybe are transitioning to more advanced part of their diagnosis. And I just sort of really wanted to echo sort of the conversation that there's still lack of understanding of what palliative care is, even among providers and the multidisciplinary team. I can't tell you how many times I've requested a palliative care consult for patients because they're having symptom management issues. And sometimes bringing in palliative care to lead that conversation and to even introduce a couple of different things that could help maybe with constipation, maybe with nausea. Those are important components to adding to that disease process. The other is there is stigma and phobia. People initially, when they get an initial diagnosis, many of you may have been in that position already. It is very scary, and trying to navigate the healthcare system, all the wording, all the medical jargon that they're just trying to process is enough. I mean, there are multiple appointments that people are going to, getting labs, getting CTs or imaging, going to their doctor or oncologist, maybe to a surgeon. And that just introducing palliative and for them to understand what palliative care is and understanding when it's appropriate to start that conversation. There's a certain sort of linear thing that sort of happens from the time of initial diagnosis as you're getting treatment. So I just wanted to offer that up. I've spent so much time with patients and families and colleagues trying to educate them, trying to pass legislation to include more palliative education among nurses and providers. And so just wanted to offer that up for, what that would mean to tonight's conversation.
Yes, thank you. And I apologize that I somehow in my brain was thinking you were a hospice nurse instead of an oncology nurse, but even more
Okay.
important that you're here because all that you said is very true. And just to echo because this is such an important point. Um, Palliative care providers have training in understanding where you are in your illness and understanding who you are. If you got a palliative care consult at your first diagnosis of a treatable cancer, a palliative care provider is going to listen to you. Likely, you're going to engage in treatment and follow along. And they're going to be the ones who's going to be able to judge, is it time for something more? What often happens is, again, out of that fear, right? You get the diagnosis, you rush into treatment. Nobody wants to talk about palliative care then. And because, first of all, nobody wants to accept that at some point you're going to die. So instead of using the word death, we now have sometimes substituted hospice because nobody wants to talk about death. So we say, oh, it's time for hospice. And now nobody wants to talk about hospice because they think it's about dying. So now they say, oh, well, maybe it's time for palliative care. And now people think palliative care is hospice, is dying. It's really a lack of a thorough conversation at the very beginning of your illness that sets the stage for what you're going to do all along the way. And so sometimes when palliative care isn't introduced early, it then kind of takes on this life of its own. And sometimes after we meet with people, we do talk about stopping a particular treatment because we determine that it's not helpful. Sometimes doctors that are ordering that treatment don't agree with that decision, but the decision and the choices we make are coming from the patient and what's right for them.
Thank you. I think we'll take two more questions. We have one in the chat, and then we have Christopher with his hand up. And then, as I said, I'm happy to stay on. We'll do a few more wrap-up things, and I'm happy to stay on for any general questions that you have. In the chat, we have a question from Lori, who's an about Act 39. Are we any closer to people being able to appoint a support person when their hands or arms can't bring the medication to their mouth?
So that is a very important question. So as Jen outlined, the entire process of medical aid in dying is meant to be driven by the patient, the decisions, whether to move forward, when to move forward, all based on the patient. And the ultimate thing that is the patient's decision is ingestion. The law, self-ingestion, so giving it to yourself. The law is written with a balance of safeguards and barriers. So the safeguards are to assure that only people who want it get it, but the barriers might prohibit some people that want it from getting it. So with a patient with ALS who's having motor issues, there are creative ways to be able to help support that patient in self-ingesting. It won't ever get to a point where somebody can help them, but there are ways that you can get creative. For example, the use of I've had people living with ALS who had a feeding tube who couldn't use a plunger, but had enough strength in their arm that a funnel could work when we taped it to their hand or other things like that. So we are learning to be creatively staying within the law and not excluding people living with a variety of disabilities, particularly physical ones, who have a right to access this. So that is a really important question. And if you have a particular patient with ALS who is interested in having the option for medical aid in dying, it is really important to have very frank, open discussions about different techniques that you might use to help them, depending on what parts of their body the illness is affecting.
Thank you. Christopher?
Hi, just to comment on the palliative care. I've been at Dana-Farber for 5 or 6 years, and nobody's ever talked about it whatsoever. And I didn't know the word, to be honest with you, until I came across it about 2 years ago when I checked out the doc, who's the radiation oncologist, and I looked up her bio, and she was head of palliative care, which time I freaked. And I just assumed that I was getting this radiation treatment just to keep me happy. So that's when I discovered palliative care. But my question actually is more mundane. I've been told, and maybe you can correct me if I'm wrong, that in order to get into hospice, your doc has to say you've only got 6 months to live. Is that correct?
Yes, you have a prognosis, meaning an educated estimate of 6 months. That is correct for hospice care.
Thank you.
All right, that was a quick one. So Leslie can be our last question for now.
And I will just add that prognostication, determining when people are in that 6 month window, is a skill and an art. And again, I can pick on doctors because I am one. They're not always very good at it. Sometimes people overestimate. One of the beautiful things about palliative care is it can be the bridge. So if you're wanting to live as long as possible, but also wanting to be sure that you don't miss your opportunity for when it's right to be on hospice, palliative care is one of the perfect things to help you make sure that you get that transition as good as it can be for you, given the realities that sometimes an advanced illness makes most of the decisions.
Leslie?
Yes, thank you. I have two questions, but if you can only answer one, that's all right. The first one is how or where or when is it that palliative care workers and even hospice workers, for that matter, ever learn about Act 39 or medical aid in dying? Like, where do they even hear about that and get that information?
So, medicine is changing all the time, and there are new treatments and new things that are going on. So any medical provider should be getting continuous medical education. Anybody that does a palliative care fellowship in a state where it's legal will learn about it in their training. But of course, it's only legal in 12 jurisdictions. And so there are many people that are getting training where it's not legal, and they would need to actively seek out training. Even some of our national organizations, like the American Association of Hospice and Palliative Medicine, of which I am a member, are not very friendly or still learning about medical aid in dying and see it still as the enemy of palliative care. And there is a lot of misperception, even amongst palliative care specialists, about it as a tool for patient-centered care. So it absolutely is possible that people would come across palliative care providers that have very little or only passing knowledge about medical aid in dying. And I'm sure I'm not the first person to tell you that sometimes patients have to teach their doctors.
Yeah. Okay.
So what was your second question, or do we
Yeah,
not have
thanks.
time for it?
So, given that we have a culture where, even within hospitals, much less out of hospitals, there's a bit of a taboo around talking about death, and no one wants to really call it death, and they're trying to call it all these other things. What efforts do you know about anywhere in the country of groups or people who are trying to open up that conversation about death in a healthy way and shift the culture a bit?
Yeah, great question. I mean, there are, old things come back around, and new ways to address things come along. Like right now, death cafes are one big thing. I think that movement that is really being driven by the populace saying, we want to talk about this thing that nobody wants to talk about. So that's a wonderful thing. I think there are pockets where it's happening. There are places where hospice is really a big part of educating, because they want people to come to them at the right time. So they need to reach out earlier. So there are small efforts being made, but not enough. And again, too much misinformation about missing out on the opportunities that palliative care can bring to the table, and seeing it only as something that you do when nothing else is working, which breaks my heart. But you can be a part of it. Like in the old days, I learned a lot about death and dying from my church community. It seems like back in the dark ages when I was young, we did more talking about it. But that has shifted over time, but it doesn't mean we can't shift back. So maybe everybody in their own way can start a little something in one of their networks, whether it's at church or the people that you work with or your family. Go for it.
Thank you.
Thank you. And again, thank you, Dr. Barnard, so much for joining us tonight and for speaking. Happy to stay on. We have just a few kind of housekeeping items. And we'll take care of those. And then Amy and I are happy to stay on and answer the questions that we can answer, or take them down if we really need to refer them back to Dr. Barnard. So thank you again for a wonderful presentation. We're so grateful. PCV, as I mentioned before, is a privately funded organization and mostly composed of volunteers. There's a very small paid staff, and they're all on this call. And so if you feel able and willing to support us, I've put the donation link to our website in the chat. And the recording of tonight's presentation will be available in the near future. There's a page on our website with all of the Exit Matters programs, and you are welcome to take a look at this one and all of them. This one will be on our website soon. We already have the previous 4 up there. And our next Exit Matters will be on Tuesday, February 24th at noon. And our guest speaker will be Nina Thompson, who's an interfaith chaplain with the UVM Hospice organization. And she will be talking about spiritual care at the end of life. And so I have just put the link to register for that program in the chat as well. So again, keep the questions coming. Christine, I see you. You've had your hand up. Go, please.
My question is more about Act 39 access than it is about palliative care. I accompanied a friend earlier this year to Vermont from Boston. I actually spoke with you, Dr. Barnard. Thank you for your help from afar. But the hardest thing that we had the challenge with was finding a doctor. And with less than 6 months to live and waiting lists to see doctors for 3, 4 months, we weren't sure that she was going to make it. And I wondered about, I did an incredible amount of searching, and I got to you, Dr. Barnard, actually from finding your name in a podcast somewhere. Um, but I wonder if there is any possibility of creating a directory of doctors in Vermont who practice this work and, just giving people more access to such a list. I called the pharmacist, he wouldn't tell me anything. I called just every place I could think of to say, how do we get connected to Vermont? So I wonder about some kind of list as a
Yeah.
resource that Patient
It's
Choices might.
there's a really important question. I mean, of people should be able to seek medical care, of course, wherever it's right for them. We heard from the gentleman who goes to Dana-Farber, right? For some people in Vermont, going out of state for your medical care makes sense. Likewise, people should be able to come here for medical care they can't get at home. But the challenges of traveling and navigating the end of your life in a state where you don't live are not good, which is why I spend a lot of my own time advocating for everybody to have this right in their home state. They deserve it and they should have it. And it's part of job A to make those services available. We do not have enough prescribers to meet the interest demand from out of state. And there are physicians who do this work, but you can't do a huge amount of it because it takes a lot of time and dedication. There are a lot of physicians who support the concept but aren't comfortable engaging in it themselves. It is a choice for patients, it is a choice for doctors. And there are still many medical providers who feel like their role is only to heal. I would say helping people die well is also a kind of healing, but not everybody sees it that way, and that's okay. And then there are people who don't support it. So over time, the number of physicians in Vermont prescribing has continued to go up. It's just slowly and it's not keeping up. And people are worried about being overwhelmed with interest. And so it is unlikely we will ever have a list of providers. Unfortunately, it's still a network. But the more we talk about it, even in our home states, if you're from out of state and you don't have a medical aid in dying law, it's important for the people caring for you, if this is something you would want to have, that they understand that. We need to build momentum and education. And unfortunately, there still is limited access for the people who want it and deserve it. And we feel badly about that, and we're doing the best that we can and moving forward every day to increase access.
Thank you so much for joining us tonight. This is a pretty robust audience for 7 o'clock on a Tuesday, and you all really hung in with us. So thank you so much.